Good afternoon. I'm very honored, Professor Ariel and Norina, for the kind invitation. At the same time, I'm so happy because I heard many speakers during the 3 days. We are from different countries, different speciality, but all we have the same vision about diabetic food. So it is so important that we are going in with the same line and the same route for prevent amputation. As you can see, here is my hospital as the left side, and on the right side, it's the diabetic foot clinic in the hospital that I work. I'm from Dominican Republic. You can see sun, sea, and sand. So it is a cordial invitation for all of you and Neurodiab for next meeting to be face-to-face in the Dominican Republic, and all will be welcome. So we'll talk about diabetic foot ulcer management. We have some facts that diabetic foot ulcers produce high mortality, 12% in the first year and up to 42% during 5 years. Between 15 to 25 of people with diabetes will have diabetic foot ulcer during their lives. Up to 85% of amputation in people with diabetes is preceded by ulcers. And the risk of diabetic foot ulcers are increased by age and by diabetes duration. And there is big difference between diabetes duration and diabetes diagnosis. Foot ulcer and infection are the most common reason for hospital admission in people with diabetes, and usually it is more than 60%. 60 to 80% of diabetic foot ulcer will heal. 10 to 15% will remain active, and between 5 to 24% will lead to limb amputation in a period of 6 to 18 months. And here we have the 7 compartment or main compartment of diabetic foot ulcer treatment or management. We'll begin with infection control. Wound infection is known as predictor, or is a known predictor of poor wound healing and amputation. The appropriate recognition of infection and the treatment with antibiotic in diabetic foot infection is imperative to improve outcomes. And at the same time, the inappropriate treating with antibiotic is associated with several adverse effects. And the most important and the most dangerous, including the antibacterial resistance. There are many classifications for the infection, but here in the IDF, we use a combination between St. Wound Score System and the Infectious Disease Society of America, IDSA, and we have a score between 0 to 3. 0, there is no infection, and the 3 is a severe infection, and some of the previous conferences covered all these topics. Before antibiotic therapy, a deep tissue culture via biopsy or curettage after debridement should be obtained. As a treatment of wound with at least 2 signs or symptoms of inflammation as empiric treatment of antibiotic. Antibiotic therapy should be targeted to aerobic gram-positive cocci in mild to moderate infection. But in severe infection, we should use a broad spectrum empiric antibiotics pending the culture sure. The IDSA recommended 1 to 2 weeks antibiotics use for mild infection, but for severe and moderate infection, 2 to 3 weeks. The second component of diabetic foot ulcer treatment is debridement. Is by definition is the removal of all necrotic tissue that will result in AIDS and granulation tissue formation, will reduce the plantar pressure at the callus area, and also will produce infection control. There are many types of debridement, but as a surgeon, we consider surgical debridement is the election of choice. The third component of the treatment is dressing. So what are the ideal characteristics of wound dressing? Should be sterile, easy to use, cost-effective, will provide a protective cover, maintain a moist wound healing environment, absorbs excess of exudate, easy to change, non-adherent, non-toxic, and non-allergic. Also, does not contaminate the wound with foreign particles, protects the wound from microorganisms, allows gaseous exchange, and control wound odor. Provides thermal insulation and mechanical protection at the same time, and one of the most important characteristics to be available in the area where you work. How to choose the dressing will be determined by many factors, including cause of diabetic foot ulcer, the location and depth of the wound, amount of scar detachment, amount of exudate, condition of wound emergence, presence of infection and pain, need of adhesions, and dressing adaptability. After that, the next component is offloading. Offloading is relieving the plantar pressure and shear stress from diabetic foot ulcer is a vital part of wound care. Promotes healing and prevent recurrence. Can be achieved by many mechanisms, including shoe modifications, boots, and orthopedic walkers. The modality choice should be based on the location of the wound and the history of PAD. The total contact costing, or TCC, is often considered the gold standard device, as reduce the peak pressure in the forefoot up to 87%. Non-removable offloading is more effective than removable one in terms of time of healing and percentage of wound healed. Surgical offloading should be only used if conservative management has failed, especially in high-risk patients. After that, we have vascular assessment. PAD is estimated to occur in 40% of patients with diabetic foot ulcer. Patients with diabetic foot ulcer and PAD have slower healing, higher amputation rate, and higher mortality rates. So all patients with diabetic foot ulcer should be evaluated to rule out the possibility of PAD as soon as we can make the diagnosis of the ulcers. And we have many modalities by pulses, ankle-brachial index, Doppler, duplex, and etc. Next, and one of the most important component is the metabolic control. If we don't have the diabetes controlled and as a global vision, metabolic control of the patient will have poor result in the treatment of the ulcers. As there are many studies demonstrate the importance of metabolic control and the outcome of the ulcer treatment. And this study demonstrates the direct relation between the size, reduction size of the ulcer and the A1C level. As you can see, if the A1C is less than 7%, the percentage of closure, but if it is 8 or more percent, this percentage is less and less. And final message, remember multidisciplinary team, it is so important, and many publications and papers about the importance of multidisciplinary team. And in this one, they demonstrate that 94% of studies reported a reduction in major amputation after institution of multidisciplinary team. And many previous speakers talked clearly about the importance of this multidisciplinary team in the outcome of diabetic foot ulcer treatment and management. So, diabetic foot team, in 2022, we have a giant list you can read from. This team will be, or should be led by diabetologists. And we have a lot of specialty, and I didn't put more because I think there is no more space, but we have more and more people who should work and who should be part of this multidisciplinary team. Remember, the key in the success is prevention and education. Always we have to prevent ulcers and we have to educate people with diabetes how to prevent ulceration, how to take care of their food daily. Thank you very much.